Practice your verbal skills. Remember this, younger docs in particular, the more you make out of an issue, the bigger they'll make out of an issue. Lead the conversation before it becomes a big deal. Anticipate the questions they're going to ask and answer them for them. That way, the less unsure they are, the less likely there is to be a big conflict there. Hello there, everybody, and welcome to another episode of your 5-Minute Friday. I'm your host, Dr. Glenn Krieger. I touched on something in one of my other podcasts that I just wanted to follow up with and make just a few minutes of it. It's about communication with your patients and in general. And the conversation I was having beforehand was about why I treat so many adults. And as I mentioned earlier, one of you reached out to me and said, Glenn, I know you love treating adults. I don't get it. Can you talk more about it? And I encourage all of you, if there's a topic you want me to talk about, just message me on Facebook and I'll gladly bring it up. But during the course of that conversation, the one-way conversation I had with you, I explained that I work in a relatively affluent area. I get patients from all over, but they're very high maintenance, as one would describe them. And I don't have a lot of problems with my adult patients, because the one thing that most people don't like about adult patients is the conversations can often be about that one single tooth or unhappiness with an outcome. And the truth is, I rarely have that, not because I'm a better orthodontist than you, but because of verbal skills. And I feel like verbal skills are a lost art. I feel like my contemporaries from 20, 30 years ago, the conversations we had and the way we could have them is very different than it is today. I feel like, I'm Gen X, and I feel like millennials and Gen Zs are a little bit more reserved when it comes to conversations. Not everybody. I don't want this to be an overreaching stereotype, but even my most outgoing millennial friends, most of them, not all of them, there are exceptions, aren't going to necessarily jump in and have the conversations that I'm going to have as early as I will have them. Now, if you're one of them who will, great. But the key is this: when you're looking at a patient, child, adult, doesn't matter, when you're looking at a patient and you see something that you think might be going sideways or something that they could be talking about, and I learned this lesson from Dr. Michael Schuster from the Schuster Center, literally in 2000, 99, 2000, around that time, and it served me really well for the last 25 years, is spot the problem or spot the question before it's asked. Because if you can do that, you disarm everything. So for instance, if I see that one of the upper centrals has a tip issue, let's call it 3 degrees, 4 degrees, nothing major, but enough that you and I can see it from a mile away. You can take one of two choices. You can ignore it and hope the patient doesn't see it, push the case through and finish it that way. That has never been my style and it never will be. If I see it, we need to fix it. If they see it, we have to fix it. Unless they're bananas, right? If you have an 80-year-old woman, which I had once, come in when I was doing restorative and say her outcome didn't make her look like Angelina Jolie, right? That's a different kind of conversation. But those are the conversations I was used to having as a restorative dentist when you do full mouth reconstructions. And you learn to solve those before you do anything, not after. But if you see an upper central is off by 3 to 5 degrees, and it's got to be fixed, right? I'm not going to finish that up unless the patient goes, know what? I'm fine with it. I see it. I'm done. I'm finished. Great. I'm okay with that. But I'll bring that up to the patient before they bring it up to me. And I might say something like, hey, by the way, I know we're supposed to be done soon, but I saw something here, and I don't know if you notice it, but I noticed this one tooth is off just a little bit. I would love the opportunity to go a little bit longer and straighten this tooth up. Now, just that conversation, there's several outcomes that can happen from it. The first one is, I don't see anything, it looks great to me, in which case, I always say to patients, fantastic. I want you to remember, I work for you, not the other way around. So if you say that we're done, then we're done. That's great. And the I work for you works in so many instances, but I work for you, meaning what you want goes. The only thing I won't do is something that's in their bad. It works against them. I won't do anything that's not in their best interest in a health way. It hurts them. Now, a tooth off by 3 degrees, 4 degrees that I see that I want to fix, but they say they're done, nobody's going to die of that. I'm okay leaving that as long as I've told them about it and they don't want to go any further. Second option is they go, doc, I see it too, and it's really bothered me, and I was going to bring it up, but let's fix this. Fantastic. And the third one is, the best one, which I love, is, doc, I've come this far, I'll do whatever you want me to do. Right? But the point is, You took control of the conversation before you finish your set of aligners and you hope to push it through and you say, okay, we're done. Do you see anything? And they go, well, this front tooth is off and, I'm really upset about it, right? And those are the conversations you don't want to have. So whenever you see anything, and I gave you a pretty mundane situation, let's just say mechanics are not working the way you want them to, right? In adults, biology doesn't always participate. Sometimes ridges are narrowed. Sometimes soft tissue doesn't want to cooperate, right? If you see, for instance, you're straightening the lower anteriors and you've been really diligent in keeping sort of your AP direction of your incisors, but even there, they've got a really narrow symphysis. They've got a thin, fragile phenotype, biotype of tissue, and you can see that there's going to be recession that's going to happen. You may not have noticed it at the new patient exam, right? But now you start seeing it's about to happen. It's okay for you to bring that up to the patient. Don't be scared of it and say to them, hey, by the way, you've got really, really narrow gum tissue here. And, genetically, I feel like at some point in your life, you're going to end up with some gum recession, whether we do orthodontics or not, which is entirely true, people. People whose gums recede during ortho are likely to have gums recede not from ortho as well, right? Ask any restorative dentist who's done it for 35 years. Thin, fragile biotypes recede. Thick, fibrous biotypes swell. That's the nature of the beast. So if you see that thin tissue, you didn't pick it up at the new patient exam for whatever reason, have that conversation with them and say, hey, by the way, I think your gums are going to start receding a little bit, not because of the orthodontic treatment, but because as we align the teeth up, it's sort of showing areas where the gums just are very narrow and there's not a lot of bone. And at some point, I may refer you to a gum specialist to get a little grafting done. But for right now, let's just keep going. That is literally the conversation I've had hundreds of times in my career. And do you know how many times people have argued with me? Zero. Because what was there to argue there? Now, if someone's gums have really receded and need grafting, I hope I spotted that at the new patient exam and said to them, at some point in your life, you're going to end up with grafting. Whether that's going to happen during treatment or not, I can't tell you. But the good news is, if it starts happening, I'll get you to my gum specialist. They'll get it taken care of and all will be good. That's it. Don't make more out of it than there is. Practice your verbal skills. Remember this, younger docs in particular. The more you make out of an issue, the bigger they'll make out of an issue. If you say, hey, I got some bad news for you. I was hoping it wouldn't happen, but during treatment, your gums have started receding. And they've really receded more than I expected them to. And at this point, I've got to stop treatment and I've got to get you to a gum specialist to take a look at this. And they may need to do gum grafting. Sometimes they add bone to it. Like if you have that conversation, excuse the expression, but you're becoming a horse's ass. You're causing yourself more grief because you can tell them the same thing without being an alarmist. Because if you think someone's going to lose a tooth, then you have to have that conversation. But if someone's going to lose a tooth, you'd better have had that conversation way earlier because +3 mobile teeth just don't form out of air. They just don't, right? If someone's got gum recession and teeth are starting to get mobile, you need to nip that one in the bud earlier. But let's take roots resorbing. Right? Someone has no history of roots resorbing ever. And all of a sudden, you take a CBCT or a pan, a SEF, whatever, and you see some roots resorbing. You can make oh my God, your teeth are resorbing, we have to stop now. Or you can say to them, hey, by the way, one of the things that's been happening, and it was in your initial paperwork, is that your roots are getting a little bit shorter. Nobody knows why this happens precisely, and the only indicator that tells us when this is going to happen to somebody is a previous history of resorption. Since you've never had orthodontics, we were never able to see this before, but now I see it. So we've got a couple of choices, and here's how we can proceed. And you go through the choices, right? And again, lead the conversation before it becomes a big deal. Anticipate the questions they're going to ask and answer them for them. That way, the less unsure they are, the less likely there is to be a big conflict there. So again, this is a massive situation that maybe one day I should do some sort of stage talk on, right? Maybe this is a lower stress in your life conversation that for 45 minutes I can give examples of scripting, of things I say just intuitively now after 32 years of when I see this is what I say. When I've got a patient who says this, here's what I say. And the same way that someone wants a 4 o'clock appointment every single time for their kid and you can't do that, they're scripting for that, right? You know that already, hopefully. But again, I hope this has helped you in some way. And remember, the takeaway from this one is spot the question that they're going to ask you before they ask you the question. That way, you give them an answer. And The great Michael Schuster taught me this. Ask the question before they ask the question. Answer the question before they ask the question. You do that, no big deal. So hopefully this helps. Hopefully I'll see you at Summit 2025 in Vegas. Go to opsummit2025.com. Again, it's clinical, it's management, it's entrepreneurial. It's going to be the best meeting of the year. And as I've told you before, do not wait to sign up like you're going to do. It's going to cost you $400 to $600 more per ticket to do that. You want to bring your team to this one because it's going to really change the culture of your practice in so many positive ways. But every 150 tickets that's sold, the price goes up $200. So go to opsummit2025.com. Can't wait to see you there and have a great day.